First of all, Warfarin Reversal from the Haematology section. So here, 57-year-old female presents to emergency department after vomiting a substance that resembled coffee grounds. She reports that she now feels lightheaded as well, and her past medical history is significant for deep venous thrombosis, for which she takes warfarin, and occasional joint pain, for which she takes aspirin, and her blood pressure 90/60, pulse 110. Which of the following substances would provide the fastest reversal of warfarin effect? So it will be the fresh frozen plasma FFP, because this patient has upper GI bleeding, and that is coffee ground emesis with the hemodynamic instability like hypotension and tachycardia, low blood pressure, and increased heart rate. That shows the hemodynamic instability. And also the coffee ground emesis, that shows the upper GI bleed in the setting of warfarin therapy, that is emergency requiring immediate reversal of anticoagulation. So here the warfarin inhibits the vitamin K dependent clotting factors 2, 7, 9, 10 plus protein C and S. So warfarin inhibits all of these clotting factors, and fresh frozen plasma will replace these depleted clotting factors and produce the effects within minutes of infusion, the fastest option among the listed ones. So why the other options are wrong? Because vitamin K do the reversal and sustain the reversal, but it takes the 6 to 24 hours to work, and it's too slow for active hemorrhage, although it is given through IV intravenously. And then the protamine that reverses the heparin, not the warfarin. And then aminocaproic acid, that is antifibrinolytic, inhibits the plasmin, doesn't replace clotting factors or reverse warfarin. Then cryoprecipitate contains fibrinogen factor 8, 1 Willebrand factor 13, useful in fibrinogen deficiency or DIC, but doesn't contain vitamin K dependent factors depleted by warfarin. So here the key concept is, in the life-threatening warfarin associated bleeding, give both the rapid factor replacement product. Factor replacement product means fresh frozen plasma or ideally PCC, the concentrate, and IV vitamin K together. The former, the first one for the immediate effect like the FFP, and the later, that is vitamin K, for sustaining the reversal. Then here the aspirin discontinuation. 60-year-old man comes to clinic for pre-operative evaluation, and the patient has severe osteoarthritis of the right knee, and an elective total knee arthroplasty has been planned. Other medical conditions are well controlled: hypertension, stable coronary artery disease. Vital signs are within normal limits. Physical examination is unremarkable. The patient is educated to avoid taking over the counter and stairs immediately prior to surgery due to risk of excessive perioperative bleeding. He is also instructed to discontinue low dose aspirin 5 days prior to surgery. Which of the following is the reason for stopping this drug in advance of surgery? So the reason is irreversible inhibition of target enzyme. Irreversible inhibition of target enzyme. Aspirin actually inhibits the cyclooxygenase 1, irreversibly acetylates cyclooxygenase 1 in platelets, permanently disabling the platelets' ability to produce thromboxane A2 for the rest of its lifespan. Since platelets are anucleate and can't synthesize new enzyme, the only way to restore normal platelet function is to wait for the bone marrow to produce the entirely new population of platelets. So it takes roughly 7 to 10 days for the platelets to reproduce. That's why the aspirin is stopped about 5 to 7 days prior to surgery, and that is the enough time to regenerate. And so here the key concept is that, because this question tests understanding that aspirin's antiplatelet effect outlasts the drug's presence in plasma, because inhibition is irreversible. Platelets can't make new enzyme. The effect only resolved via platelet turnover, not the drug clearance. Effect will be reversed via platelet turnover, not due to the clearance of drug, that the clearance of aspirin. And the next one is antiphospholipid syndrome related question, that a 26-year-old woman is being evaluated for glomerulonephritis, a photosensitive skin rash, and arthralgia. Rapid plasma reagent test is repeatedly positive despite negative. Treponema pallidum enzyme immunoassay testing. Coagulation study results are as follow: bleeding time normal, and activated partial thromboplastin time prolonged, prothrombin time normal, platelets 2,40,000, and this patient is at greater risk for which of the following complications? So the correct answer is recurrent miscarriages, because this patient is having antiphospholipid syndrome and increased risk of coagulation. The hypercoagulable state will be there, and also due to that there will be the history of recurrent miscarriages. So here this describes that antiphospholipid syndrome likely secondary to underlying SLE like the glomerulonephritis and photosensitive rash and arthralgias are there. So the kidney is involved, also the giants, and also the rash, the skin involvement in the SLE, and the antiphospholipid syndrome is due to underlying SLE. So here are the diagnostic clues: false positive RPR with negative treponema pallidum immunoassay, and these are the diagnostic clues: isolated prolonged partial thromboplastin time with normal prothrombin time. The lupus anticoagulant paradoxically prolongs the activated partial thromboplastin time. The lupus anticoagulant prolongs the APTT in vitro, and despite actually causing the hypercoagulable prothrombotic state in vivo, it doesn't cause a true bleeding tendency. So antiphospholipid antibodies promote placental vascular thrombosis and infarction. So in antiphospholipid syndrome, there will be the thrombosis and infarction that is promoted by antibodies, leading to recurrent first and second trimester miscarriages. There will be the miscarriage in first and second trimester. One of the hallmarks clinical criteria for antiphospholipid diagnosis, antiphospholipid syndrome diagnosis, along with the venous or arterial thrombosis. And why the other options are wrong? Because heavy menstrual bleeding, APS causes clotting, not bleeding, and the prolonged APTT is an artifact, not a true coagulopathy. Painful hemarthrosis seen in hemophilia 8 and 9 deficiency, not APS, and sclerodactylia finding out systemic sclerosis, not the lupus or APS. Okay, and here the last option that was tabes dorsalis, a late manifestation of tertiary neurosyphilis. This patient syphilis test is false positive, not true infection. So key concept in this question is a prolonged activated partial thromboplastin time that doesn't correct with mixing studies. In a patient with hypercoagulable or thrombotic history, not bleeding, points to lupus anticoagulant, an in vitro artifact reflecting an in vivo prothrombotic antibody, not a true factor deficiency. Okay, the next question is related to acute hemolytic transfusion reaction. 34-year-old man is brought to hospital by ambulance after being involved in motor vehicle collision, and he was unrestrained passenger and sustained considerable trauma. On arrival to emergency department, he is hypotensive, bleeding from several sides. Patient receives an emergency blood transfusion as part of the resuscitation efforts. Abdominal ultrasound reveals subplanic laceration and blood in the peritoneal cavity. On the way to operating room, the patient develops difficulty breathing, chills, and pain in the chest and back. Pain in the chest and back, and difficulty breathing and chills are there. So urine drainage from the Foley's catheter was initially cleared but now appear brown in color. Which of the following most likely the cause of this patient finding? The correct answer is complement mediated cell lysis. So complement mediated cell lysis. Here you can see in the question that there is hematuria because the color of urine has changed, brown in color. And the correct answer is complement mediated cell lysis. Most commonly, it is caused by ABO incompatibility, the acute hemolytic transfusion reaction that is caused by ABO incompatibility. So here, ABO incompatibility triggers a type 2 hypersensitivity reaction. Reformed IgM antibodies against donor RBC antigen bind the transfused cells and activate the classical complement pathway, forming the membrane attack complex and causing intravascular hemolysis. And this releases free hemoglobin. and also generates the anaphylatoxin that contributes to the fever, chill, hypotension, flank, or back pain. So the key concept in this is, and why the other options are wrong, because the CD8 lymphocyte mediated cytotoxicity, this describes the type 4 cell mediated mechanism. Endotoxin induced tumor necrosis factor alpha describes the septic or bacterial contamination of blood products. IgE mediated, that is the type 1 reaction, hypersensitivity reaction, anaphylactic reaction, urticaria, breathing possibility, anaphylaxis. And then the option E, that explains the vascular deposition of immune complexity, describes the type 3 hypersensitivity reaction. For example, in serum sickness or delayed hemolytic transfusion reaction, which occur days later via IgG and extravascular hemolysis.